في هذا اللقاء. واللقاء اليوم هو تقديم حالة يقدمها الدكتور محمد طلافة، مقيم سنة رابعة في وزارة الصحة، المركز الوطني للصحة النفسية. تفضل دكتور محمد.
شكرا دكتور وليد. Good evening everyone. Thank you all for your participating in this case presentation. Today we will talk briefly, today we'll talk about interesting case presentation. We will talk about history taking, mental state, risk assessment, case formulation and summary, and we will have a brief discussion about something or some matters in forensic psychiatry. Okay, so my patient, I have seen him firstly on Sunday, 8th of September 2024 in Abu Ubaidah Hospital in North في الأغوار الشمالية. BF is a 28-year-old gentleman. He's divorced 3 times. All were engagements, no kids. He's a Muslim, lives in Waggas, North Aghwar, secondary school educational level. He is unemployed, just occasional daily worker currently, and he came alone. The chief complaint was بدي أفتح لك قلبي. So I think this was a clue or hint that the patient wants to disclose very important information. Okay, so the history of presenting illness, BF is 28-year-old patient, medically free with no known drug allergy. The patient was doing well until 2017, when he has had family conflicts after losing his job in army forces following many times work absence, and having a long-term relationship breakdown for 9 years duration with his cousin following several rejected engagement trials. كان بعلاقة حب مع بنت خاله وتقدم لها عدة مرات وصار رفض، وبنفس السنة تقريبا خسر عمله نتيجة تغيبه المتكرر عن الجيش. At that time, mainly on 2017, he started to drink alcohol, about half liter of vodka, 2 to 3 times weekly as a self-medication after feeling depressed and hopeless. In addition, he tried to kill himself by overdose. He took 10 tabs of ibuprofen in the same year. On 2018, he has stabbed his brother twice by a knife after a conflict with him. He described that nothing significant, just was a trivial conflict, and he stabbed him maybe after anger episode, for which he was imprisoned for 6 years duration as a murder attempt case. اعتبروه حالة شروع بالقتل. انسجن من 2018 ل 2023. During the present duration, he has had low mood, poor sleep and appetite, feeling hopeless and worthless. In addition, he was socially isolated, thinking all the time in his beloved cousin. Moreover, he had physical assault with a prisoner and he hit his face by a scalpel without any legal consequences. يعني الهيستوري تاعه بلش I think حتى من قبل دخوله للسجن، وحتى في السجن كان عنده violence again، ضرب سجين في وجهه بشفرة، بس ما صار عليه أي مشاكل قانونية. طيب, since escaping the prison last year, he has been having low mood, anhedonia, extremely poor sleep, initial insomnia and inability to have deep sleep, poor appetite associated with significant weight loss, about 15 kilograms in the last year. In addition to having low energy, poor concentration, guilty feeling, overthinking, feeling hopeless and helpless. Moreover, he has persistent death wishes without active suicidal thoughts, intents or planned. On the last 3 months, he has been having elementary auditory hallucinations and obsessions of contamination, followed by repetitive hand washing, bathing and frequent room cleaning several times daily. Since the last 2 months after his cousin's engagement, بنت خاله اللي كان يحبها خطبت, he started having or been having active homicidal thoughts against his cousin and her husband. He has the intent and plan to kill her husband in their marriage day 1 month after by kidnapping and burning him in a car, in addition to revenge from his cousin by burning him by burning her face using acid. هو عم بيخطط كان انه يخطف زوج بنت خاله في يوم عرسه بالسياره ويحرقه بالسياره، وكان بيخطط ايضا يحرق وجهها باستخدام مي النار حسب اقواله حسب كلامه. طيب, last week he has tried to kill his brother again by a knife after an anger tantrum. Luckily, his brother was escaped. He denied any history of mania or hypomania symptoms in the past. Also, he denied using any illegal substances currently. طبعا كون المريض كان لحاله اضطريت انه اتواصل مع اهله على التليفون. And according to his brother and mother by the telephone, he's doing well without having any behavioral disturbances during the last year. They confirmed that he don't use any illegal substances and denied any recent conflict even with his brother. يعني denied the incident. I think خافوا من تبعات قانونية, and I think mostly due to stigma. Okay, so the past medical and past surgical and medication history all were free. No previous episodes of significant traumas and no known drug allergy. The past psychiatric history, he was seen only once in the prison and was given amitriptyline. However, he has not taken it due to side effects. No previous hospitalization or any other psychiatric results. Forensic history, he has 12 legal records. طبعا one of them اللي هو كانت murder attempt for which he was present for 5 years, and the remaining records were financial records. كان عليه شيكات ومطالبات مالية. The substance history, he denies any illegal substance currently. He started drinking alcohol at age of 21 for 1 year duration, 2017-2018, half liter vodka 2 to 3 times weekly. And he denied any other substances. The last alcohol intake was on 2018 before the prison. And he started smoking at age of 15 with his school peers. And currently he is a heavy smoker, 4 packs daily. Okay, his family history. His father died sudden on 2013 at 47-year-old by MI. And his mother is 49-year-old. She has hypertension and DM, and she works as a farmer. He has 2 brothers and 3 sisters. He's the first rank. According to him, his aunt and uncle have mental retardation. And his mother has had depression in 2014 following death of her husband. And she was given antidepressants, but she stopped them upon her choice. The pre-morbid history, before 2018, he was social, responsible, and successful in his job, according to him. And according also to him, he was very jealous in his cousin's relationship with ideation of infidelity that has not reached delusional intensity. He has had frequent phone checking and chasing her. كان يضل يلاحقها وكان عنده شكوك فيها مستمرة بس ما كانت delusional. He described his relationship as position desire. يعني وصف علاقته فيها إنه كان عنده حب التملك إلها. Since adolescence, he has been having unstable self-image with fear of abandonment, frequent anger episodes during his relationship, and occasional suicidal threats following conflicts with her. Moreover, he has impulsivity in spending and maybe substance use, alcohol mainly, and he has unstable mood and extreme mood changes. Okay, so the social and sexual history, he lives with his family, with good family relationship with them, including his brother, اللي حاول يقتله. He is dependent on them financially. His family has very poor socioeconomic status. Currently, he is socially withdrawn and he has no friends currently at all. Sexual history, he is heterosexual, straight orientation, and he has never been engaged in any sexual activity due to religious and social reasons. Okay, the developmental history, he's a product of normal vaginal delivery, full term, no antenatal or postnatal complications or any ICU admission. His milestones were normal according to him. In the school, he has had poor academic performance. He had several friends, no antisocial activity or school truancy during his childhood or adolescence periods. He attained normal puberty at age of 13. And his father died when he was 18 years old, and he described that incident as very painful for him. And since that time, he became responsible for his family financially. Okay, the work record from 2014 to 2017 in the military forces, 4 years of duration, from 2018 to 2023 in the prison, and in the last year He just worked as a daily basis worker occasionally. Okay, on the mental state, he had good self-care and hygiene. He was groomed and looked similar to his age, and he dresses appropriately to his age, gender, and weather. He looks dysphoric and anxious. Behavior can cooperative, partial eye contact. Rapport was established successfully with him. No abnormal gait, posture, or movements. There was some psychomotor retardation. Speech was spontaneous, coherent to the point, low tone and volume, كان monotonous speech and normal articulation. المود subjectively وصفه كان very sad, سيء جدا. على الأفق كان dysphoric, restricted reactivity, fixed and congruent with the stated mood, poor sleep and appetite, low energy, normal sexual desire, and persistent death wishes. على thoughts, no delusion could be elicited, obsessions of contamination and cleaning compulsions, no active suicidal thoughts currently, but he has active homicidal thoughts against his cousin's husband and also for his cousin. His thought process was linear, goal-directed, without any formal thought disorder. Al perception, he has forms of hallucinations or perceptual disturbances were present. Cognition was fully conscious and alert, oriented to place and person, partially oriented to the time. He said that كنا إنه إحنا بال 2023 intact attention and concentration على weekdays backward, average intelligence and knowledge, poor recent memory, normal abstract thinking, poor test and personal judgment. And he was insightful as he realizes that he's having symptoms that need psychiatric assessment following Google search. صار يبحث عن الأعراض اللي عنده على الجوجل وطلع له إنه لازم يراجع طبيب نفسي وبناء عليه قرر يجي. طيب my differential diagnosis is أنا كنت بفكر إنه كون الهيستوري كان old كل هاي اللايف كرايسيس اللي صارت معاه فموستلي فكرت بالpersistent depressive disorder الأول term اللي هو dysthymia specifier mainly with persistent major depressive disorder severe with mood congruent psychotic features أو another option إنه يكون major depressive disorder in recurrent episode يعني صار عنده episodes سابقة وهي recurrent و current episode is severe with psychotic features. Also, I put OCD in differential as he has obsessions of contamination. Also, we could think about cluster B personality disorder. We could think about antisocial personality and borderline. Antisocial, there's no evidence of antisocial or conduct history before age of 15. Although he has 12 legal records, but I think we can rule out antisocial personality easily. The main thing that we can think of is borderline personality disorder, as he exhibited many of the criteria of borderline. But I think, again, it's a little bit difficult to diagnose borderline at this age retrospectively. Also, I put schizophrenia at the bottom of my differential diagnosis just because he has auditory hallucination. And I thought it could be his violence and his murder attempts. It could reflect a delusional belief for him. And maybe he has negative symptoms for schizophrenia, but it was unlikely for me. And the last thing, substance-induced mood disorder, as he has a previous history of alcohol. So it could be substance-induced, but again, the patient denied this, so this is very also unlikely. Okay, so the risk assessment, my patient is a 28-year-old single male, unemployed with a past psychiatric history of undiagnosed depression and no past medical history, who presented to outpatient clinics for depressive symptoms and homicidal ideation. Biologically, he has a first-degree parent, his mother, with a history of depression. He denies illicit drug or alcohol use, therefore it's not a substance-induced mood disorder. He has a history of depression and currently has a major neurovegetative signs and symptoms consistent with another major depressive episode or, as we told, ongoing depression. He has homicidal ideation with a plan to kill his cousin's husband by kidnapping and burning him in a car, in addition to harm his cousin by burning her face with an acid, and is therefore at high acute risk of harm to others. Psychosocially, his several life crises started from job loss, relationship breakdown, and long prison statement were the catalyst for his current ongoing mood disturbance. Therefore, he requires inpatient hospitalization for acute safety and stabilization, as he poses a significant risk of harm to himself and others. Okay, so if we talk about the case formulation, بنحكي عن etiology, the predisposing factor for this patient, genetically he has family history of mood disorder, depression in his mother, the death of his father when aged 18, the personality traits, maybe the borderline traits, and the previous depressive episodes that he has. The precipitating factors are the job loss, relationship breakdown, and long prison statement. The perpetuating factors are the ongoing family arguments, engagement of beloved cousin, and the ongoing unemployment and being dependent on his family. Okay, my treatment plan and goal, given his diagnosis, I mainly think about major depressive disorder, severe depression, and no previous treatment trials, and being the SSRI as the first-line treatment. Also, because he has obsessions, I choose to start him on fluoxetine, also due to energizing effect. And the plan was to increase the dose and augment it with antipsychotic olanzapine. The olanzapine for psychosis, and also he has the poor appetite and sleep, and as being very recommended augmentation strategy for resistant depression. Also, I consider CBT as soon as possible once the depressive symptoms slightly improve. ACT may be required later on if no response to these strategies. And also very important, as due to inability to work in a regular job, as he has a criminal record, he needs a financial support and secure job are needed to reduce this stressor. Regarding the prognosis, Mr. BF has a good chance of full therapeutic response to the planned treatment, especially if the financial problems can be improved. However, given his complex history and the predisposing factors noted above, he is at increased risk of further depressive episodes, particularly at times of stress. Okay, so my action plan was to transfer him to the National Center of Mental Health. He refused the admission idea. However, I gave him the transfer paper, and I called his uncle, was informed by the phone that he needs urgent admission. I plan to do close monitoring every week for this patient, and full labs were ordered. And the most important thing here, that the police was informed. I called 911, and I told them about that he poses a significant risk, and the harm intent or the killing crime intent for his husband and for his cousin and her husband. Okay, and I will talk later why I do this action. Also, I started him in, as I mentioned, fluoxetine 20 milligram per os 1 by 1 a.m. and olanzapine 5 milligram per os 1 by 1 at the time. Okay, so and I gave the patient my phone number to keep in touch with him, and I talked with him on daily basis. Maybe I don't know to say it's fortunately or unfortunately, the police they don't do any action for him. ما عملوا أي شيء الشرطة، أو ما عملوا أي إجراء. تواصل مع المريض يوم السبت مساء وحكى لي اقتنعت بفكرة الادميشن، وفعلا رتبت معه انه يجيني يوم الاحد. On Sunday 15th of September 2024 he was admitted to the National Center of Mental Health. Again, he came alone, and he reported decreasing in his homicidal thoughts, and his sleep became better than before. However, his mood was still low. His affect was still dysphoric with constricted reactivity. No delusion were elicited, and he still has had elementary auditory hallucination and obsession of contamination. On physical exam, he is a medium-built man, no scars or deformities or tattoos, no thyroid manifestations like goiter, myxedema, or exophthalmos, no self-harm marks or any needle marks, and he has normal vital signs. Full investigations were ordered, including CBC, kidney, liver, fasting blood sugar, lipid profile, thyroid function, urine drug screen, and ECG. All were normal. The plan was to keep him in a close observation, and full details history from his family to be taken later by the psychologist, MMPI and mixed depression inventory. And his medication doses were both increased, and also consider the CBT at this stage. So the fluoxetine became 20 milligram twice AM, and olanzapine dose was increased to 10 milligram 1 by 1 at bedtime. On the follow-up in Tuesday 17th of September, the patient was seen. طبعا هو دخل لمجموعة ثانية مش ما كنت أنا فيها. So the patient was seen by his doctor and he reported feeling better with good sleep and appetite. He denied any hallucination or any homicidal thoughts. In addition, no delusions were present. Their plan were to keep him in the same RX. On Wednesday, 18th of September, just one day after, I have seen the patient in the ward. He looked much better than the admission day. His mood was reactive, and he confirmed that he has no homicidal ideation, and he was nagging for discharge due to his medical condition. His cousin and her husband, full names, address, and working details were taken for safety measures. And my plan was same RX. قعدت مع المريض وهو حكيت له انه لازم ناخذ كل هاي المعلومات just in case انه ما تابعت معنا او لمسنا خطوره عليهم، لازم يكون عندنا المعلومات الكامله. والمريض كان very cooperative وفعلا زودني بكل هاي المعلومات، اسمائهم وعناوينهم بالكامله الرباعيه وايضا عناوين شغل. Okay, unfortunately, on Thursday, 19th of September, the patient's uncle came to the hospital and discharged him upon his responsibility against medical advice, and he was given the medication for 2 weeks. طبعا هون صار في conflict بينه وبين المقيم اللي خرجه، انه لازم حكيت له لازم ما يتخرج لانه he has risk to the others، and انه حكيت له انه لازم يكون على الاقل نعمل discussion مع الكونسلتنت بالنسبه للديسيجن عليه. Anyway, the call phone was done on the same day مع المريض to emphasize the close follow-up, and I told him to come back after 10 days. Okay, so after 10 days, on Sunday, 29th of September, again, مستشفى أبو عبيدة. At that time, he still has had low mood, poor sleep, anhedonia, poor concentration, low energy, and feeling hopeless and helpless. However, he denied any active homicidal or suicidal thoughts or any death wishes. No delusions could be elicited. His obsessions were much better, and he described hypnagogic hallucinations. My plan was to increase the fluoxetine 20 milligram 3 by 1 a.m. and to increase olanzapine 5 milligram 3 by 1 at bedtime. And medical report was given for him with major depressive disorder, severe with psychotic features to the social security. طيب تقرير الضمان الاجتماعي مشان يساعدوه ماديا. The last follow-up was on Sunday, 13th of October. The patient reported improvement in the mood, sleep, and other neurovegetative symptoms. However, he still feels amotivational and hopeless, sometimes with inability to start working again. Again, no active psychotic features or suicidal or homicidal thoughts currently. My plan was to keep him in SEMRX. And note, at this point, patients for sure need CBT, but due to poor socioeconomic status, he can't afford any private sessions, and unfortunately, it's not widely available in Ministry of Health clinics. So therefore, I arranged with him to come to Erbidi clinics to start him in psychotherapy. My case summary, this is a 28-year-old male patient, medically free. He was presented on 8th September with a long duration of severe depressive symptoms with psychotic features, mainly auditory hallucinations, obsessive symptoms of contamination, and active homicidal thoughts against his cousin's husband on the last 3 months. He has history of one suicidal attempt on 2017 and murder attempt of his brother on 2018, for which he was present for 6 years of duration. In addition, he has had repeated anger tantrums and violence. No previous mania or hypomania episodes, and he denies any illegal substance currently. His family history is significant for depression in his mother. Currently, he is much better than first presentation. He reported improvement in his mood, sleep, and appetite, and even smoking consumption. هلا صار يدخن half pack daily من 4 باكيتات لنص باكيت. In addition, he denies any homicidal thought or hallucination currently, and objectively, he looks much better with reactive mood and facial expressions, no delusions or any other psychotic features currently. Okay, so we will have a brief discussion now just about how to assess the dangerousness of the patient. The predictors of potentially crime is the repetition, if there's a previous history of violence, and of course, this patient has repeated previous episode of violence. الانكونجروبيليتي اللي هي عدم القدره على الاصلاح، maybe اذا كان مريض مثلا anti social يكون very difficult to deal with him. Unpredictability، عدم التنبؤ باحداث او صعب نتوقع شو ممكن يعمل، وفعلا المريض هون كان unpredictable كل الفايولنس اتاكس تاعونه. Untreatability اذا كان ايضا يصعب علاجه زي ما حكينا. Others factor like male, young, low socioeconomic, poor social support, and repetitive stressors, all of them were present in this patient. This slide also summarizes the risk factor for harm to others. This from the Oxford 7th edition of psychiatry. We have personal factors, illness-related factors, and factors in the mental state and situational factors. Regarding personal factors, if there's any, as we told, previous violence to others, antisocial, impulsive, or irritable personality traits, if he is male and young, a recent life crisis, poor social network, divorced or separated, unemployed, social instability, and a parent with history of violence. The illness-related factors like psychotic symptoms, substance abuse, treatment resistant, poor compliance with the treatment, and if stopped medication recently. Factors بالmental state مثل irritability, hostility, suspiciousness, any thought of violence towards other, threats of people to whom patient has access, any planning of violence, persecutory delusions, delusion of jealousy, delusion of influence, acute command hallucination, especially violence to others, suicidal ideas with severe depression, lack of insight about illness, the situational factors like situational associated with the previous violence, as we told, and ready availability of weapons. Okay, so also I want to discuss the 4 ethical principles اللي حكوا عنهم American philosophers Tom Beauchamp and James Childress and British doctor and philosopher Rannon Gillon. حكوا عن autonomy. The autonomy اللي هي respecting the patient wishes and freedom of choice based on understanding of all benefits and risks for any treatment, and to keep all information confidential. The beneficence, which is acting in patient's best interest, and non-maleficence, avoidance harm to the patients and others. يعني مش بس احنا بهمنا to avoid harm to the patient, also to the others. And the last one is the justice, which is the treating problems equally with equitable distribution of resources to the needy. Something is called ethical dilemma, which presents where there is 2 more principles conflict with one another. So in this case, the autonomy and the principle of keep the patient information confidential conflict with the principle 3, non-maleficence, to avoid harm to others. So I think we should weigh the benefits, to avoid harm is much more important than the autonomy of this patient. So we have to break the confidentiality for this patient. So we will talk also briefly about the situations where we can break the confidentiality. The first situation that we use here, the homicidal thoughts, which is called Torosov law. Torosov law, we have 2 laws. The law 1, which is published in 1974, duty to warn the victim, and the law 2, duty to protect the patients from harming others by maybe do even obligatory admission or forced admission, and to also to inform the police. Also the second case, إذا كان عندنا suicide ممكن نبلغ الأهل أو نبلغ حتى الشرطة إنه في حالة إنه suicidal thoughts، على أساس أيضا ممكن نعمل له admission بهاي الحالة. If there is a child abuse case confirmed, qualifying court order. إذا كان عندنا patient with life-threatening responsibilities, like إذا كان عندنا pilot، إذا كان bus, lorry, taxi driver, or working in army forces. So مثلا على سبيل المثال إذا كان مريض bipolar, schizophrenia أو غيره، كان unstable مثلا بيشتغل pilot، لازم نبلغ الايجنسيز المسؤولة عن هاي الحالة. أو مثلا مريض كان عنده epilepsy، أو كان مثلا عنده narcolepsy، sudden يصير عنده sudden seizures attack or sudden sleep attacks. Also we have to inform باليو كي بيسموها ال DVLA driving vehicle license. فبنفس الشيء ممكن نبلغ إدارة الترخيص مثلا المركبات إنه هذا المريض unfit مثلا to drive. أو بالarmy forces أيضا نفس الشيء، لأنه very serious job. For sure sharing information with staff members, insurance company limited information لغايات شركات التأمين. وأكيد upon patient request إذا طلب منا تقارير في حالات مثلا للتنمية أو لغيره. طيب, a home message from this case. The first thing, don't rush. Give the patient all the time. تقريبا قعدت مع المريض 1 hour. بالرغم إنه كان في مرضى كثير، بس إنه أنا صريت إنه to give as much time as I can to the patient because it was very serious. And also remember, very important, that you have medical legal responsibilities to protect the patients and other people. Be empathetic and patient and never be judgmental. Always have plan A, B and C. يعني أنا اليوم لما قيمت المريض عملت close monitoring، أعطيته medication، كتبت له الترانسفير paper أو الادميشن. Also I called the police, I called the family. So I just يعني مشيت بكل البلانز الممكنة to guarantee to prevent the harm for the patient and the others. Be honest and never cheat the patient. هاي حقيقة أنا بعرف هلا إذا بتوافقون الرأي بهاي المسألة. أنا I was honest with my patient and I told him that I have a duty and medical legal responsibility to inform the police and the victims or the people that could harm them. The patient actually understand that fully. يعني هو تفهم الإشي بشكل كامل. So I was honest with him. And the last thing, just to don't underestimate your job role, so you can prevent crimes and catastrophes. And thank you so much.
شكرا جزيلا دكتور محمد. Excellent presentation. يعني there are few points was he ever in full remission from depression?
No, actually no. He described I just أنا حكيت معه امبارح yesterday and he described the improvement about 70%. So I think he is in partial remission currently.
No, I mean over the years. He was depressive. His depressive disorder continuous, or there were episodes and remissions?
يعني حكيم هو he described إنه all that time يعني بال previous 5 to 6 years all the time إنه كان his mood was low وكان عنده تقريبا أغلب أعراض major depression. بس أكيد ما كانت ممكن in the same intensity. يعني هو حكى مثلا بفترة السجن كان عنده أصدقاء وبفترة من الفترات يعني كان manage and deal يعني خلينا نقول good in the prison. بس actually I can't يعني guarantee إنه كان عنده full depression ولا just maybe mild depression يعني as dysthymia وبعدين صارت عنده major depression the last 1 or 2 years.
So what is your final diagnosis?
Okay, my final diagnosis is major depressive disorder, maybe as I told, persistent depressive disorder or recurrent episode. The current episode is severe with psychotic features, and also it could be a borderline personality disorder. But again, I can't I can't be sure of this diagnosis actually.
What were the results of MMBI?
actually حكيم للاسف المريض ما قعد غير 2 أو 3 أيام عندنا بالمستشفى، وواحده من الايام كان هوليدي على ما اذكر، كان في يوم عطله رسميه، فللاسف ما انعمل الفحص، وهو خرج خلال اي ثينك 3 ايام فقط، فللاسف ما انعمل يعني الفحوصات ما انعملت، وحتى الاهل ما اجوا تاخذ منهم فول ديتيلز، وعمه اجى وعمل له ديسشارج اجينست ميديكال ادفايس.
يعني also you mentioned that this is psychotic. What are the psychotic features in this patient?
هي السايكوسيس اللي عنده حكيم جاست الهالوسينيشن، كانت جاست elementary auditory hallucination. حتى طبعا البيشنت never exhibited any first rank symptoms or any يعني خلينا نحكي hallucinations consistent مع
elementary hallucination be considered as congruent or incongruent?
صراحة مزبوط يعني I'm not sure but اعتبرت انه elementary I think mostly ممكن تكون مع المود او الدبريشن اكثر، يعني اتوقع مش مع السايكوتيك disorder او schizophrenia، بس I'm not sure.
What's the prevalence of hallucination in the general population?
Okay. I'm not sure صراحة، بس اتوقع نسبة يعني ممكن تكون عالية شوي، لانه it could be normal phenomena يعني، خصوصا اذا hypnagogic or hypnobombic hallucination.
No, I don't.
But I'm not sure.
Hypnobombic or hypnagogic.
In general, I don't have an idea صراحة. دكتورة ليالى عم تحكي لنا على 20%. 20%.
يعني هو 15 to 20%. ف يعني this is quite important in
Yeah.
So to say that this probably it's part of his illness or it's just something there. Why did you go to borderline personality تحديدا in your
هلا حكيم هو يعني خلال هو طبعا his relationship started at age of 16 وخلال طول هاي الفترة كان عنده fear of abandonment، خوف دائما من الهجران، كان عنده unstable self image، كان دائما بيحكي لي انه ثقته بحاله دائما قليلة او مهزوزة. كمان كان عنده الامبulsivity بالسبندنج كانت واضحة جدا، مثلا بيحكي لي حتى لما كان يشتغل كان بيحكي لي كان عندي استعداد اصرف 1000 دينار باليوم الواحد بين انه استاجر سيارة ومصاريف والى اخره. الكحول اتوقع يعني I'm not sure إذا نقدر نعتبرها impulsivity لانه هي كانت ريفليكشن ممكن للدبريشن او السيلف ميديكيشن، فممكن ما نقدر نعتبرها impulsivity واضحه كسبستنس يوز. برضه كان عنده
وهذه اللي ذكرتها انه مستعد يصرف مبالغ كبيره بيوم. could that be hypomanic episodes?
Yes it could be يعني بس يعني حاولت اطلع كثير يعني بالهيستوري انه if there is any manic or hypomanic symptoms the patient denied any يعني symptoms like that.
Is there any scale that you could use which may give you a hint that this patient probably had bipolar disorder?
Bipolar disorder scale. I'm not sure. I think ال MMPI ممكن يفيدنا أتوقع.
لا scale specific.
No
ما بيعطينا.
I'm not sure. ما عندي فكرة.
تمام. دكتور نزار تفضل.
شكرا جزيلا دكتور وليد كالعادة. شكرا دكتور محمد يعطيك العافية.
العفو حكيم.
إذا دكتور وليد يسمح لي شوية أخذ وقت حتى أتكلم.
نعم.
أول مرة أبدي بفد practical point. أنا بالنسبة عندي المقيمين تبعي لما يقدمون كيس عادة أطلب من عندهم يخلون سلايد نمبر حتى من أريد أناقشهم أقول السلايد الفلاني كان إلى آخره. هاي نبدي بها. Okay. There are some notes that I would like to talk about, and then after that I will ask some questions just like Dr. Walid did. The first note is about you are obliged to inform the police and report. You mentioned some cases correctly, absolutely, and I'm glad that Dr. Sudad is with us. For children, sometimes, of course, you have to report when there is danger to the child, either from the parents or from other people. But sometimes you have to make a balance. If you are sure that you have got services that will protect the child, when the child is in the social services or in the care services, that's okay. Otherwise, you are really gambling with the life of the child if you report that child to the authority. That is as far as reporting is concerned. As far as the formulation is concerned, last night at 10 o'clock, I attended another Zoom meeting with the University of Rochester, and there was some guy lecturing to his junior colleagues, junior doctors, and it seems to me that University of Rochester is that university where Engelman worked, who invented the biopsychosocial model approach in psychiatry. What they did, they made a table, يعني عملوا جدول في 3 rows and 4 columns. The rows were bio, psycho, social. والcolumns كانت predisposing factor, precipitating factor, perpetuating factor, and protective factors. هذه الإضافة اللي ضافوها هناك. ويعني خلينا نقول مثل الكلمات المتقاطعة they filled in all these blocks and that was the formulation. It's a very practical way of approaching patients in general and of course your patient in particular.
Yes.
Yeah, these are the notes that I wanted to talk about. As far as the questions that I want to ask you, I'll ask you the questions one after the other. إما تكتبها أو بس تتحملني at the end you can answer all the questions. The first question is, in one of the slides you said escaping prison. Did this person escape from prison or was he released from prison? That's one. Because escaping prison to me is هو هارب من السجن وبهالحالة من واجبك أنه تخبر عنه. This is one. Secondly, you talked about some obsessional symptoms. Are these symptoms enough to qualify for the diagnosis of obsessive compulsive disorder for which you chose fluoxetine for the treatment of this patient, thinking of depression with obsessional features or obsessive compulsive disorder? That's another point. Another question is, how reliable is this person? The person is giving you the history by himself. If I were you, you said that you called the family for some points. If I were you, I will take a complete collateral history. I will not wait for the psychologist to do that after a day or two. I will do that while the patient is with me because in a way, and that is another question, how sure you are that this person is not making this history because he wants the unemployment benefit, the report that you said you will write or you wrote to the social services. يعني هل هو إجا حتى تنطي هذا الريبورت? So the collateral history will help you to make sure that the claims of this person are genuine and they are true. And even you said the family were afraid to tell you everything because of stigma or whatever it is. Now, another question is, being a non-Jordanian, I really don't know whether the army is voluntary or is it a tajnid al-ijbari. In case of a tajnid al-ijbari, there is no financial benefit from that. But of course, if it is tatawwu', if it is voluntary services, in that case, yes, there is money. So I want to know that. The other thing is, you didn't mention, you didn't highlight whether this patient had deliberate self-harm or not, because you really concentrated on the borderline personality disorder. And of course, this is an important part of the borderline personality disorder. So we want to know whether this deliberate self-harm was there or not. And as far as the financial state, you said the family depended on him at the beginning, but now he is depending on the family. This is a bit, it needs some clarification. And another point, this might be my last point, you mentioned ECT. I can't find really good reasons to mention ECT in this patient. I mean, what are the criteria in this patient that will qualify for the use of ECT in a patient like this? These are my questions, and I'm waiting for your answers. Thank you.
Okay, thank you so much, Doctor. First of all, he was released from the prison, not escaped. فخلص هو مدة محكوميته وطلع من سجن 7.5 وعربي أتوقع بيطلعوا 5 أو 6 سنوات، فطلع بشكل طبيعي. الأمر الآخر اللي حكيت عنه I think إنه هلا بالنسبة الأوبسيشنز actually لا يعني الكرايتيريا I think it's not يعني fair enough to diagnose him as OCD. But يعني حطيتها بالديفرنشال diagnosis but because he has this obsession of contamination. But يعني my final diagnosis I just يعني I think بالdepression, بالsevere depression. خصوصا انه يعني الobsessions improved very quickly على الميديكيشن. ف I don't think انها actually OCD يعني disorder. طبعا التجنيد هو كان موظف امبلويي يعني في الجيش لمده 4 أو 5 سنوات مش تطوع. ايش في كمان شغلات بالنسبه للديليبريت سيلف هارم، هو كان جاست وان سويسايدال اتمت بال 2017 بعد ما الريليشن شيب بريك داون. طبعا تقدم لها عده مرات واهلها رفضوا، بعدين حتى صار في عنف، يعني ضربوه وهددوه انه خلص ما تتقدم لها ولا شيء، فبناء عليه حاول ينتحر، اخذ 10 حبات بروفن. no other previous يعني history of suicide or deliberate self harm. بس خلال علاقته هو حكى انه كان عنده احيانا suicidal threat لما تصير مشكله بينه وبينها، بيحكي له انه كان يهدد ويحكي انه انا اذا بتتركيني بنتحر، او لما تصير مشاكل بينه وبينها. فكان في عنده هاي recurrent suicidal threats مش not attempts. فمشان هيك انا ممكن حتى فكرت في البوردر لاين بيرسوناليتي. بس مشكله انه ريتروسبكتيفلي انه نشخصه بهذا العمر I think it's a little bit difficult. دكتور بتوافق من الراي؟
نعم. طيب وبالنسبه للاي سي تي؟
لا الاي سي تي صراحه يعني جاست ان كيس، يعني قلت توقعت ممكن تكون تريتمنت ريزيستنت ديبرشن لانه فيري كومبلكس، بس يعني حطيتها يعني اكيد مش
يعني تريد تسوي نفسك حلو قدام الممتحن مثلا اذا هذا الامتحان. زين، اخر شيء دكتور، يعني I quite agree with you that this patient has many features of personality disorder. هو ما قارئ الكتاب حتى يصير borderline personality disorder. He might have features of different kinds of personality disorder. Now, unfortunately, we abandoned the DSM-3 as you know، اللي كان فيه او DSM-4 ما اتذكر، اللي كان فيه المالتي اكسيال classification. يعني why not this patient has depression and underlying personality disorder? It could happen in the same person at the same time. تمام؟
عفوا دكتور، بس الصوت قطع شوي اخر شيء، انه ليش ايش عفوا borderline؟
السؤال هو in the previous DSMs we had the multi-axial classification for patients. اللي كان في مثلا وحده من الاكسس الدايجنوسيس، الاكسس الثانيه كان البيرسوناليتي disorder. فwhy not this patient is suffering from depression and accompanied by an underlying personality disorder and not necessarily only borderline personality disorder. لأنه أنا قلت لك هو ما قرأ الكتاب وإجا قال أنا عندي هاي الفيتشرز. يعني he has features of personality disorder from different، يعني for example he tried to kill his brother، أو خلينا نقول he attacked his brother twice. So he didn't learn from mistakes and from imprisonment. This goes with antisocial personality disorder. Now he blames others for his problems. This goes with borderline personality disorder. So if we might say that this patient is suffering from dysthymia or persistent depressive disorder or major depressive disorder plus a personality disorder. تتفق معي بهالحالة؟
يس حكيم، طبعا انا يعني اي ثينك انه ممكن كثير احتمال كبير يكون بيرسوناليتي ديس اوردر، بس اميلي فكرت بالبوردر لاين اكثر. طب فكرت طبعا بالانتي سوشيال، بس ما كان عندي اي ايفيدنس اوف كوندكت اور اني انتي سوشيال اكتيفيتي اور اني سكول تروانسي before age of 15، وهي واحده من الامبورتنت كرايتيريا بالانتي سوشيال بيرسوناليتي. وبعدين يعني حتى الفايلنس اعتبرتها ممكن تكون جزء من الامبولسيفيتي للبوردر لاين او نتيجه الدبريشن بالسيفير ديبريشن تاعه والفاميلي كونفليكت. فهو كانت يعني مش ما بنقدر نعتبرها ممكن فولي انتي سوشيال اكتيفيتي، وما في عنده الكريمنال ريكورد اكسبت محاوله يعني قتله لاخوه كانت ناتجه عن نوبه عصبيه وغضب شديد. هلا مساله انه عم بيحاول برضه تو انه ينتقم تو ريفنج من فروم هيز كازن اند هير هازبند. بتصور انه ايضا ممكن مش شرط تكون انتي سوشيال، لانه هو بنعتبرها باشن اوف كرايم، واجين بوردر لاين ممكن يكون امبلسيف او بدون او مش شرط حتى بوردر لاين، واحد سيفير ديبريشن. واي ثينك انه he has many losses in his life starting from job, his relationship, his prison. I think maybe he has the intent to يعني انه ينتقم. خلينا نحكي
دكتور، هذه مع الانتقام هذه مو impulsive at all، هذه مع سبق الإصرار. لأنه هو
صحيح.
he's planning to attack his cousin and her husband. هذا يعني سبق الإصرار.
اوكي صح. there is a plan. yes.
شكرا جزيلا. شكرا.
يس
دكتور سداد.
العفو دكتور، شكرا لك.
شكرا جزيلا. First of all, I think this is an excellent presentation. It's a very interesting case. There are a lot of transcultural issues in it. Okay, and I think well done. Okay, well done. But there are a few things here. I mean, you see, I mean, the duty of a psychiatrist, forget about what the American says, what is written in these textbooks, and so on. What you need to think about when you have a forensic case, the most important thing is risk assessment and management, right? I found what happened. I mean, one could easily question you about the risk assessment. He's a high risk to others, okay? The fact, you know, there's a simple formula, isn't it? The formula is the attack itself or the incident multiplied by the frequency. The fact that he attempted to kill somebody and went to prison for 6 years will make him a high risk forever. High risk forever. And this is the most important part of forensic psychiatry, is risk to other, how you're going to manage that, okay? Secondly, he's also a risk to himself, okay? Because we know he is a multi-impulsive person, isn't he? He's multi-impulsive. He drank alcohol, attempt to do that and that, left the army, and so on. And I appreciate as well that this guy suffered from a lot of losses. Now, the other thing is regarding what's wrong with him, right? Now, think always, you see, in psychiatry, don't stick to try and be imaginative sometimes, all right? Don't stick to criteria. Oh, I have to either fulfill the criteria of DSM-4 or not. Nowadays, to be honest with you, the diagnostic criteria are very fluid, okay? They are very fluid, and this is a problem with psychiatry, okay? You can easily use ICD-11 or DSM-5 and stick. What you think of in forensic psychiatry, think of the mental disorder. That's one circle. The other circle is a trait disorder. What traits he has. You don't need to fulfill the criteria on borderline. You are quite wrong to say, well, he cannot be borderline. He has borderline traits. And borderline personality disorder may manifest at the age of 50, by the way, 15% of them. So what we have a chap who has a trait disorder. He's impulsive. He's borderline. He turns against others. He can turn against himself. He has all the features of antisocial personality. And the fact he committed a crime does qualify him for that. Secondly, he does have, yes, a mood disorder. Yes, the question Dr. ask you, okay, and is it mood congruent or mood incongruent, okay? And I think you should really, I expected you to answer that, okay? There are obsessional features, part of the depressive disorder, a major depressive disorder. I think your treatment plan it was great, and I would have done it precisely the same. I mean, Dr. Walid really questioned you on that, and I didn't hear you really answering his questions. Now, your management with medication was brilliant, but I still think I would have grilled you on how are you going to manage this risk, because the risk is forever. Yes, there are transcultural issues maybe in Jordan, but I think you need to involve social services, psychology from the start. You have to have a multidisciplinary team meeting, see, well, how we are going to contain that risk, because he is a very high risk to other. But stating all that, your presentation was brilliant, and your management, I think, was brilliant. And thank you very much. Yeah.
Okay, thank you so much, Doctor. I agree with you that this is a very risky patient. هلا دكتور احنا صراحه يعني انا was shocked انه لما بلغت البوليس طبعا first of all هم اخذوا الامور سيريس واخذوا الفول ديتيلز وين عنوان سكنه واسمه الرباعي ورقم الوطني والى اخره. فاي صراحه I expected to take action from them, لكن انصدمت انه they don't do any action صراحه. this was يعني they don't do an action at all.
I mean, they should really. I mean, it is, these things are taken seriously.
في خطأ في الموضوع. الشرطة ليس لديها سلطة لمنع
نعم.
الجريمة. السلطة هي مع الحاكم الإداري
نعم.
الذي يستطيع أن يقول للشرطة اذهب وأحضر هذا الشخص لأنه
نعم.
يشكل خطورة، هو الحاكم الإداري.
صحيح.
في المنطقة اللي كنت فيها هو الشخص المناسب لتبليغه، وهو الذي يخاطب الشرطة. الشرطة جهة تنفيذية ولا تحمل صفة الضابطة العدلية إلا إذا جاءها قرار محكمة أو جاءها من الحاكم الإداري.
نعم.
لذلك إحنا بالإدخال القسري نكتب للحاكم الإداري حتى
صحيح.
يورد للشرطة. لا تستطيع الشرطة أن تذهب مع الفريق النفسي، فريق المستشفى اللي بنبعث نرسله حتى تدخل المريض، وهي ليست مفوضة لا من محكمة ولا من حاكم إداري. فلذلك يعني النقطة الأساسية لك ولكل الشباب، لازم نعرف إنه بهيك حالة التصرف بيكون التواصل مع المتصرف وليس مع الشرطة. الشرطة ستأخذ المعلومات وتنتظر أن المتصرف سيكلمه. هذا من ناحية. الناحية الثانية
تمام.
يعني إني أنا أكتب له فلوكسيتين ولنزابين ويروح، أنا هل تنتهي الخطورة بإني أنا كتبت هذا؟ لا تنتهي. هل إني وثقت وأعطيت تحويل؟ لا تنتهي. المرة القادمة الاتصال فوري يجب أن يكون بالمتصرف في المنطقة التي أنت فيها. إلا في سؤال من أنا حجاء الدكتورة شيرين. Should we be cautious in regard of being frank about having homicidal thoughts because he might use having a file, a psychiatric hospital in the future as an excuse? Of course لا شيرين. يعني في homicidal tendency نعم. عنده ملف بالمستشفى، هذا لا يعفيه من العقوبة. يعني لما إذا قتل فعليا سيتم تحويله للتقييم، سواء بغض النظر ماذا كان التشخيص، وستسأل المحكمة عن أنه هذا كان مسؤول عن عمله أم غير مسؤول. فلذلك لابد أن نكون مش بس فرانك بالهوموسايدال تندنسي in very much in detail حتى نكون على ثقة. هلا فلنفرض انه واحد عنده depression، عنده personality disorder، I would expect انه عنده mixed personality disorder زي معظم personality disorder. Yeah, and he could do anything not this year, maybe next year. ممكن next year لما بنت خاله تجيب ولد يروح يقتل الولد وبنت خاله وأبو الولد. ممكن، وممكن يتحول من المحكمة للتقرير، وهذا لا يعيقنا عن إنه إحنا الآن بنقيم وضعه ونخبر عن وضعه. دكتورة ليالي عندك سؤال، تفضلي.
I'd like to ask about the onset of impulsivity and mood swings. دكتورة هي described
خلي الدكتورة ليالي تحكي.
تفضلي.
شو
تفضلي.
مساء الخير.
يا أهلا.
مساء الورد.
يعطيك العافية على البرزنتيشن، الكيس حلوة. بس أنا كنت بدي أسأل عن التشايلد هود، مش كثير كان في عنها كثير داتا. يعني أنت حكيت كان في بور أكاديميك بيرفورمانس، صح؟
صحيح.
وبلس أنا بدي أسأل يعني الإمبulsivity والمود سوينجز، لأنه ذكرت إنه يعني he is impulsive و he has severe mood swings.
Yes.
فالconcept لهاي الsymptoms يعني started since when?
هلا على كلام هو الريليشن شيب بلشت تقريبا عمر ال 15 او 16 سنه relatively early age. فsince that time يعني he described that he has the impulsivity والmood swings. هلا regarding السكول performance يعني ما كان في evidence of truancy بقدر انه هو جاي من very poor social class، ما في اهتمام كثير بالeducation او التعليم على ما اتوقع. ف يعني بس هاي الفكره. الشيء العائق الاخر كان الاوبستكل بالنسبه لي all the information كان from the patient alone. طبعا حتى عن طريق التليفون لما كنت اتواصل مع الاهل الام والاخ
ما كان في any collateral.
ان يس نوت ريلايبل، يعني كانوا حتى ينكروا انه صار مشكله، ينكروا انه ما عنده اي مشاكل، يعني كانوا نوت ريلايبل وكانوا نوت حتى ترستد انه تاخذ منهم اي معلومات. وحتى يعني بدي احكي هاي الكلمه، كانوا مش ريلايبل لدرجه حسيت انه في يعني somehow اوف بوردر لاين اي كيو او لو اي كيو عند الاهل، يعني كانوا بيحكوا شغلات نوت ميك سنس ات اول. فما كنت بقدر احصل اي معلومات، فكل شيء كان من
هم
المريض
غالبا
لحاله.
يعني غالبا إذا عندهم فكرة هم خايفين من أي إجراء، خايفين
صحيح.
إنه يتم إيقافه، كونه عندهم يعني شعور إنه هو ممكن يأذي، فبكونوا ديفنسيف وممكن سيكريتيف. إنه
يس.
وهذا شيء لازم يكون في الاعتبار، ويكون عندنا أيضا في الاعتبار إنه يعني صحيح كمية المعلومات في العيادة يمكن كانت محدودة، بس هو
نعم.
لو بالمستشفى بقي يوم أو يومين، يعني عادة في هيك حالات في المستشفى ما بكفي لا ساعة ولا 2، يعني بدنا very extensive history بتفاصيل بشكل شامل عن الأمور.
يس.
دكتور
طيب
جلال
دكتور
عندك سؤال الصور.
تفضل
خلينا
تفضل
نشوف
دكتور.
دكتور جلال، أو بس نسمع رأي الدكتور جلال. تفضل.
مساء الخير، يعطيك العافية يا دكتور.
مساء الورد،
هلا
الله يعافيك.
بالحقيقة أنا يعني عندي سؤال، إنه بنت خالته وفي رفض لإلها، وهو عم يحكي عن علاقة استمرت حوالي 6 سنوات. يعني
9 years. يس.
هو عم يلاحقها 9 سنين ولا في علاقة فعلية؟ لأنه أهلها عم يرفضوا، فأهلها عم يرفضوا، هذا بيعني إنه هو عنده سمات أشياء معينة. بيت خالته هن اللي عم يرفضوا، واللي تزوجها هو ابن عمه. فهذا قد يشير فعلا إلى أنه في عنا بالطفولة، الشيء اللي حكت عنه دكتورة ليالي، أنه بالطفولة ربما يكون عنده في شيء، أو بالمراهقة ربما يكون في عنده أشياء كمان سيئة. لما بيحكي هو أنه على تريفيال كونفليكت مع أخوه، بيطعن أخوه. فنحن لما بيكون هذا الشيء أحيانا بتدلنا على البارانويد، يعني بين البارانويد وبين الأنتي. حتى الملاحظة اللي حكاها دكتور نزار على أنه لا يتحمل مسؤولية في شغلة ثانية، أنه هو لم يتقن عمل. أبدا ما عنده عمل مستقر، وراح الجيش يعني كحدا يمكن شيء إداري أو شيء خدمي أو شيء. فهذا أمر أيضا مهم. في عند اخواته 2. هلا انت حكيت منتال ريتارديشن بطلت مستخدمه، هي بس هيك للاشاره يعني السريعه، ما عاد مستخدمه بالتصنيف الحالي، صار
disability.
بالضبط. بس يعني هيك الملاحظه.
السجن.
فالفكره يعني سأل الدكتور وليد، بدي ارجع اسال انا لو سمحت، لما بتقول elementary hallucination، شو كانت هي بالضبط هيك يعني شو كان يقول لحتى يعني هيك نسميها هيك، لانه بدي اربطها بشغله ثانيه لو سمحت.
اوكي. هلا هو he described the hallucination انه elementary، انه كان بيحكي زي صوت يعني ازعاج هيك وز او صوت طنين، او يعني ما كان في any clear voices يعني حسب اقواله، بس كانت
طيب.
ترو هالوسينيشن. يعني كان بيحكي انه بسمعهم بايدين التنتين وبصير يتلفت حواليه لما يسمعهم وما بيلاقي اي سورس اوف ذا ساوندز.
اوكي. هلا بالحقيقه نحن في عنا يعني البنت اللي بحبها واللي بده يتملكها واللي عم يلاحقها 9 سنين، او كان في علاقه 9 سنين، تزوجت من 3 شهور، وبالتالي قد تكون الحاله هي ستريس ريليتد، وخاصه انه هو جاي يقول لك انه انا بس بدي احكي، بدي فضفض، وبالتالي هو ربما يكون فعلا غرقان بهيو. بهذا المعنى انا الافكار اللي عم يحكيها بالحرق وكذا قد لا تكون delusions ولا obsessions، قد تكون فانتازيز. ففانتازي، الفانتازي ببطل يعني يمكن الكلمه اللي حكاها دكتور نزار انه عن سابق اصرار والتصميم، هون لا، يعني هو في فانتازي، والفانتازي هو حتى الان ما زال يعني هو ما جاي بيقول انه انا ما بدي اقدم على هذا الفعل، رغم انه هو يعني عنده امبالسيفيتي يعني بالصرف. وحتى الامبالسيفيتي يمكن تكون لها علاقه فعلا ب يعني بسوء المحاكمه اكثر ما يكون لها علاقه بشيء ثاني، رغم انه يعني مثلا لا تطبق يونغ ولا تطبق اي شيء لنشوف المانيا. بس حقيقه حتى يعني اختيار الروح على الجيش قد يكون له علاقه فعلا بالسمات الشخصيه، سواء كان بارانويد ولا سوشيال. يعني انت بتعرف دكتور تماما انه الكلاستر بي هو فيه خلطه. يعني يمكن هيك يعني من حلاوه الامريكان انه عملوا حطوهم خلطه وحده، بتلاقي شيء نارستيك، وبتلاقي شيء انستيبل، بتلاقي irresponsible، بتلاقي كل هدول الشغلات. فانا اللي شايفه انه قد يعني ينظر للموضوع بانه ستريس ريليتد، بس يعني بتشخيص هيك. اما عندي سؤال مهم يعني هيك حاب اتعرف عليه، شو اللي خلاك
نعم.
تفضي الساعة ورغم انه هو جاي يقول لك انه انا بدي فضفض؟ شو الشيء اللي هيك شغل بالك، لفت يعني سريريا، شو الحس السريري اللي صار عندك؟
نعم. هلا الدكتور هو لما اجى عندي وبلش يحكي طبعا I was active listener، وطبعا يعني I showed the empathy، ويعني بلشت اسمع له. المريض بتعرف صار في نوع من الرابورت بينه وبينه، فبلش يحكي to elicit this serious information. I think this is not easy to elicit some important and serious information like this from this first visit. فلما بلش يحكي لي عن الموضوع اللي صار معاه وانه عنده الانتنت والبلان، فاكيد وقتها يعني كان يمكن حوالي صار لي ثلث ساعه ونص ساعه مع المريض. وقتها حسيت انه لا this is a very serious thing. ووقتها يس يعني انا لما اذكر قعدت معه 1 اور، رغم انه كان في مراجعين كثير وبلشوا يضجوا، بس يعني I don't rush، وكملت معه for 1 اور، وتواصلت مع العائله، ولما خلصت دوام تواصلت مع الشرطه وخليت رقمي معاه. يعني حاولت دكتور كل safety measures to take them all. و at the same time يعني بلشت على ميديكيشن دايركت، وظليت على تواصل معاه لحد ما قدرت فعلا اقنعه. يعني كان بالنسبه لي something I'm proud of that انه I persuade him of the admission idea. بس unfortunately انه ما كملنا معاه في العلاج. هلا في نقطه انا اخيره كنت ممكن حاب اسالكم واستشيركم فيها. I think الاجراء القانوني as forensic psychiatrist، هل انه اذا اجى حدا من العائله سواء ام اب او عم او غيره هو في عنده الانتنت to harm someone، I think انه it's not allowed انه to discharge him against medical advice، لانه he poses a significant risk to others، right؟
هلا حسب القانون الأردني
نعم.
هذا هو المشكلة، إنه أنتم دخلتوه فولنترلي
yes
لحاله، ما
نعم.
بنحسبش compulsory admission. في الكومبالسري ادميشن لازم يكون في اتفاق كامل ما بين اللي يدخلوا ولي امره اللي هو عمه مع الطبيب. يعني لو انا هذا اجى يدخل بصر
نعم.
على عمه انه يجي يوقع كومبالسري عشان
نعم.
يكون عندي الصلاحية امنع الديسشارج against medical advice.
اوكي.
آه.
دكتور هو ده